Good evening. I am presenting to you this evening from the invitation of my dear friend Elidio Mijares. But I also want to bring to your attention that my connection with Venezuela goes many decades for the last century. My dear friends Jorge Monroy, Pedro Munoz, Osvaldo Guerra have been my colleagues and friends for a number of years. I first met Dr. Elidio Mijares at the International World Conference in San Francisco, and that led eventually to an email exchange and an invitation this evening. So my 21st century Venezuelan connection is Dr. Elidio Mijares. Here we are at the 9th World Congress of Head and Neck Cancer in San Francisco. And only recently I received an invitation from him to come and share my views on the management of advanced thyroid cancer this evening with you. In the surgical management of advanced cancer of the thyroid gland, numerous issues come to surface. When the primary tumor is confined within the thyroid lobe, there is not much discussion, and the patients are easily cured by either an ipsilateral thyroid lobectomy or a total thyroidectomy. However, when thyroid cancer extends beyond the thyroid gland to involve the adjacent structures such as the trachea, larynx, esophagus, recurrent laryngeal nerve, or even major vessels, a significant and extensive workup is required. This includes imaging studies such as CT scan with contrast or MRI scan, adequate endoscopic evaluation with suspension laryngoscopy and tracheoscopy, and thereafter a thorough discussion between the patient and the surgeon regarding the plan of surgery. So let us begin by first understanding the biology of thyroid cancer and the biological progression of thyroid cancer before we embark onto surgical management of advanced thyroid cancer. The prognosis in thyroid cancer, as is well known, depends largely on the histology of the primary tumor and the gross extent of the tumor. A majority of well-differentiated thyroid carcinomas are confined to the thyroid gland, and nearly all are curable. Patients with poorly differentiated histology or those with extensive tumors need aggressive surgery, and even majority of those are also curable. On the other hand, patients with anaplastic carcinoma are rarely curable and are a matter of continued interest and investigation to find newer methods to control this otherwise horrible disease. To plan appropriate treatment, one therefore needs to understand the biology of carcinoma of the thyroid arising from the follicular cell. Follicular cell-derived thyroid cancers go through natural tumor progression from a well-differentiated carcinoma, eventually leading to anaplastic carcinoma. This tumor progression model exists in real life. Majority of cancers of follicular cell origin differentiate either as a papillary or a follicular carcinoma. Nearly 85% of patients fall in that group, and they carry a very good prognosis. About 10 to 15% of patients progress along this tumor progression model and present with a tall cell or a poorly differentiated carcinoma with a negative impact on outcome and thus somewhat guarded prognosis. And eventually a distinct minority, less than 2% of patients present with anaplastic carcinoma, which are rarely curable. Now, while this tumor progression is taking place in about 10% of patients, we do have clinical parameters which lead us to appreciate that tumor progression is taking place histologically. Tumor size gets bigger. Extrathyroid extension becomes manifest. Risk of distant metastasis increases and mortality increases as this tumor progression takes place from differentiated to anaplastic carcinoma along this slope. Surgical management of thyroid carcinoma, therefore, is relatively straightforward. If the primary tumor is intrathyroidal, unifocal, or even multifocal, but confined to one lobe of the thyroid gland, a ipsilateral lobectomy is curative. Generally, these are tumors less than 4 centimeters in diameter with a normal opposite lobe. Even small tumors confined to the isthmus without any nodularity in the lateral lobes can be cured by simple isthmectomy, whereupon a gross total resection of the tumor has been achieved. On the other hand, total thyroidectomy is required when there is bilateral disease or even bilateral gross nodules in the thyroid gland, when there is gross extrathyroid extension, extensive nodal metastasis, a large tumor more than 4 centimeters in diameter with a poorly differentiated histology, and to facilitate radioactive iodine treatment in those patients who present with distant metastasis. The prognostic factors in thyroid carcinoma are well known and have been repeatedly shown to be the same in various different data sets. Data from the Mayo Clinic, Leahy Clinic, Karolinska Institute, and Memorial Hospital, each institution having a large series, have shown that the independent factors impacting upon outcome are patient's age, histological grade, presence of distant metastases, tumor size, and extrathyroid extension. Extrathyroid extension has been a uniformly negative prognostic factor for thyroid carcinoma. Patients who have extrathyroid extension clearly have a worse outcome in the long term with attrition over the years. But this is for patients with gross extrathyroid extension. Microscopic extrathyroid extension, on the other hand, does not have the same negative impact as gross extension. In fact, the long-term outcome of patients with no extrathyroid extension shown in the blue line and microscopic extrathyroid extension on the green line have essentially the same long-term outcome and an excellent cure rate. Therefore, microscopic extrathyroid extension has been removed from the AJCC staging system in the 8th edition. Microscopic extension no longer upstages the tumor to a T3. It is only gross extrathyroid extension which upstages the tumor to a T3 tumor. If the tumor involves strap muscles with anterior extrathyroid extension, it would be staged as a T3 tumor, a T3B rather, and if it involves the posterior structures such as the trachea, larynx, esophagus, or recurrent laryngeal nerve, it would be staged as a T4A tumor. Now, those patients who present with gross extrathyroid extension inherently have an aggressive behaving tumor. These tumors do not necessarily have just the risk of local failure, but they have an increased risk of regional failure and distant failure, as shown in purple, compared to intrathyroidal tumors shown in blue, where the risk of local recurrence, regional recurrence, and distant metastasis is infinitely low compared to those with gross extrathyroid extension. The most frequently involved structures in the central compartment by gross extrathyroid extension are anteriorly the strap muscles and posteriorly the recurrent laryngeal nerve, shown here, followed by trachea, esophagus, larynx, and major neurovascular structures in the neck. This is data from 153 patients in over 3,500 patients treated at Memorial Hospital in the last 20 years. A collective review published by Nixon showed similar data showing that invasion of strap muscles occurs in nearly half of the patients with gross extrathyroid extension, followed by recurrent laryngeal nerve, trachea, esophagus, larynx, and great vessels. All of these, however, occurs in less than 10% of patients. Nearly 5% of patients with thyroid cancer present with gross extrathyroid extension. These patients, generally staged as T3 or T4A, need to be studied well and in detail with a well-planned extensive surgical procedure to achieve a R0 resection if we are aiming to achieve a cure. The principles of surgery for extrathyroid extension are that all gross tumors should be removed, achieving a R0 resection. Preserve functioning structures, preserve vital structures, maintaining a balance between tumor control and best functional outcome. Remember, there are adjuvant treatments available, but they are truly adjuvant treatments and not in lieu of incomplete surgery. Adjuvant treatments will not work if the surgical resection is incomplete. Management of minor extension anteriorly to involve the strap muscles can simply be managed by resection of the strap muscles along with a central compartment lymph node dissection, as shown in this patient, showing the surgical field following total thyroidectomy with resection of strap muscles and central compartment lymph node dissection from hyoid to innominate artery and from carotid to carotid, preserving at least one parathyroid gland with its blood supply intact and achieving complete total clearance of the thyroid cancer. Invasion of the recurrent laryngeal nerve, on the other hand, can occur by two mechanisms. One by posterior extension of the primary tumor encasing the recurrent laryngeal nerve near the cricothyroid membrane, as you see in this cartoon, or by a cluster of matted metastatic lymph nodes in the tracheoesophageal groove, encasing the recurrent laryngeal nerve, causing its dysfunction or paralysis. The management of those patients where there is invasion of the recurrent laryngeal nerve requires significant preoperative assessment and, more importantly, intraoperative judgment and exercise of wisdom before sacrificing an involved functioning nerve. Make sure that the patient does not have preoperative vocal cord paralysis, and that means the larynx should be always examined for vocal cord function preoperatively. If the vocal cord is already paralyzed, sacrifice of that nerve involved by the tumor is of no consequence. But if the nerve is found to be involved or at risk during surgery, where preoperative nerve function was intact, one needs to follow the following steps. Evaluate both lobes of the thyroid gland first. Assess whether the invasion or risk of the nerve is unilateral or bilateral. Preserve the functioning recurrent nerve if possible. Look on the opposite side before sacrificing a functioning recurrent nerve. If the nerve has to be sacrificed, consider a nerve graft or anastomosis between the stump of the recurrent nerve and descendens hypoglossae or ensa hypoglossae nerve to maintain tone of the vocalis muscle. A secondary laryngoplasty may be necessary if there is a laryngeal incompetency or grossly hoarse voice. Invasion of the larynx, on the other hand, occurs infrequently, and that can occur either by direct infiltration of the tumor through the thyroid lamina with invasion of the thyroid cartilage and extension within the larynx, or tumor extending around the posterior border of the thyroid cartilage into the paraglottic space. In these situations, a partial laryngectomy, either only of the framework of the larynx, may be enough, or you may require anterolateral partial laryngectomy if the involvement is unilateral. Here is a case in point. This patient was sent to us after an open biopsy of a mass adherent to the thyroid lamina, which turned out to be papillary carcinoma. The patient had bilaterally functioning vocal cords. Here is a surgical field of the same patient. Patient's chin is up here, the chest is here, and here is the right side of the neck, right common carotid artery. Neck dissection has been completed, right recurrent laryngeal nerve preserved, right lower parathyroid gland preserved, and the right thyroid lobe has been mobilized. This is the inferior constrictor muscle. And here you see the tumor directly infiltrating the thyroid lamina, requiring resection of the thyroid lamina, but preserving the inner perichondrium of the larynx, of the thyroid cartilage. This is the surgical field after removal of the specimen, a spinal accessory nerve, carotid artery, a recurrent laryngeal nerve, trachea, the midline of the thyroid cartilage, and here is the inner perichondrium of the right side of the larynx, having removed the right thyroid cartilage. This is the post-operative appearance of the patient some 7 years following surgery without any evidence of local recurrence. This patient eventually died of thyroid cancer with distant metastasis 9 years following her surgery, but with no evidence of local recurrence. Partial laryngectomy may also be feasible in patients who have invasion of the subglottic larynx, as you see in this patient, where the lower border of the thyroid cartilage is involved with tumor infiltrating through the cricothyroid membrane and involving the anterior ring of the cricoid cartilage. Endoscopic view of the larynx with a 0-degree telescope shows the left vocal cord, the right vocal cord, and tumor in the subglottic larynx anteriorly shown very vividly. Now, we all know that the subglottic larynx is a relatively functionally silent area. There are no functionally viable structures in the anterior subglottic larynx, and therefore that area is easily amenable to surgical resection. Here is the further endoscopic view of the subglottic tumor involving the cricoid cartilage and up to the first tracheal ring. This is the surgical field of the same patient. Patient's chin is up here. This is the area of the invasion of the lower border of thyroid lamina, cricothyroid membrane, and cricoid cartilage, as well as first ring of the trachea. The strap muscles at that area have been divided to be resected. Here is the preserved right recurrent laryngeal nerve and the left recurrent laryngeal nerve to retain function of the larynx. The area to be resected has been outlined with electrocautery, and here is the separation of the trachea between the first and second tracheal rings, separating the thoracic trachea and the laryngotracheal complex up here. Now, a through and through resection is completed with the surgical defect showing the left and the right stump of the cricoid cartilage, the defect in the thyroid cartilage, the undersurface of the right vocal cord and the left vocal cord, and the surgical defect achieving R0 resection of the tumor. Reconstruction of this surgical defect will be completed with an anterior flap of the tracheal wall, which would be shifted up to achieve a framework repair and watertight closure, as you see here, restoring the continuity of the airway, retaining laryngeal function, and achieving a R0 resection. That's a surgical specimen showing the completely resected tumor with a stump of the thyroid cartilages on both sides and the cricoid cartilage here and the first tracheal ring here. Total laryngectomy is rarely required when patients present with massive tumor or obstructing and bleeding tumor, as you see in this patient with an extensive thyroid carcinoma involving the entire laryngotracheal framework anteriorly and perforating through into the subglottic larynx, causing ulceration and hemorrhage. Here is another patient with a tumor in the subglottic larynx requiring total laryngectomy due to airway obstruction and hemorrhage leading to asphyxia. Invasion of the airway further distal to involve the cricoid and trachea requires further careful assessment by imaging studies and endoscopic assessment to assess the cephalocaudal extent of airway invasion. Here is a case in point of a patient who has a cricotracheal invasion from thyroid carcinoma, left lobe of the thyroid, right lobe of the thyroid, tumor from the isthmus invading the cricoid cartilage and proximal cervical trachea. That's the surgical defect of the same patient. Patient's chin is on the right-hand side. Here is the larynx, stump of the cricoid cartilage, and the resected cricothyroid membrane, and a portion of the cervical trachea. The invasion was a bit more to the left-hand side rather. So we were able to preserve the lateral wall of the trachea on the right-hand side, permitting a tracheal flap to repair the defect in the larynx by rotation of the trachea in 180 degrees to achieve a framework repair, a watertight closure, reconstruction of the airway, retention of the function of the larynx, and achieving a R0 resection. Here is the same patient's MRI postoperatively in sagittal view, showing complete restoration of a patent airway. Invasion of the trachea has been described extensively in the literature, although it occurs very infrequently. Hermes Grillo described 4 levels of invasion of the trachea: superficial invasion, level 1 and 2, and through and through invasion as level 3 and 4. Level 1 invasion can be easily peeled off the trachea, and partial shaving off the tracheal cartilage can be accomplished with level 2 invasion. But when the tumor infiltrates through the tracheal cartilage into the submucosal plane of the tracheal lumen, or fungates with a tumor compromising airway into the tracheal lumen, a through and through resection of the trachea is necessary. So the invasion of the trachea can be managed by a variety of techniques, from shaving to sleeve resection. The most commonly practiced operation is sleeve resection with primary anastomosis of the trachea. Here you see a coronal tomogram, coronal MRI view rather, of a patient with a extensive papillary carcinoma involving the proximal cervical trachea, compromising the lumen of the airway. Endoscopic view of the trachea shows a fungating tumor from the left lateral wall of the trachea, compromising the lumen of the trachea and causing airway obstruction. This is the intraoperative surgical procedure. The endoscopic assessment of this patient's tumor required resection of 6 rings of trachea, beginning at the first tracheal ring and up to the 7th tracheal ring, a true sleeve resection in continuity with the primary tumor, as you see in this surgical field. This is the lower border of the cricoid cartilage, and here is the distal cervical trachea, or I should say mediastinal trachea, with the cervical trachea to be resected. There is a surgical defect, a defect of about 4.5 centimeters, mediastinal trachea here, larynx here. A primary anastomosis, end-to-end anastomosis between the thoracic trachea and cricoid cartilage can be accomplished with interrupted proline sutures and by avoiding tension with suprahyoid release. A primary anastomosis in a watertight fashion can be accomplished, as you see here. This is the surgical specimen showing a monoblock resection of the primary thyroid cancer with intratracheal tumor requiring resection of the lower border of the cricoid cartilage on the left-hand side, sleeve resection of the trachea, and neck dissection, all accomplished in a monoblock fashion, achieving a R0 resection, reconstructing the airway, and maintaining the competency of the airway for the patient. Invasion of the esophagus occurs even more infrequently, and most often when it occurs, it usually involves the muscular wall of the esophagus. As shown in this cartoon, thyroid cancer rarely infiltrates through the full thickness of the esophageal mucosa and in perforating through the mucosa into the lumen. Most commonly, it involves the muscular wall of the esophagus, whereby resection of the muscular wall is enough, preserving the mucosa and thus the continuity of the lumen of the esophagus. Here is a case in point of a recurrent carcinoma of the thyroid involving the muscular wall of the esophagus. And this is the surgical field. Patient's chin is on the left-hand side. Mediastinum is here. This is the trachea, the right carotid artery, and the esophagus showing excision of the muscular wall of the esophagus, but preserving the mucosa and the anatomic continuity of the lumen of the esophagus. We did a multivariate analysis of the factors which would require consideration when you deal with patients with gross extrathyroid extension. And the factors we analyzed were patient's age, presence of distant metastasis, poorly differentiated histology, and we also looked at incomplete resection as well as tumor size. Suffice it to say that for local failure and regional failure, incomplete resection were statistically significant factor, emphasizing the point that complete resection is crucial if we are going to obtain loco-regional control. Remember also that even though the patient may not be cured, loco-regional control of thyroid cancer in the neck is crucial to maintain the quality of life of the patient for the length of life the patient will live. In the 153 patients out of over 3,500 patients we treated over the last 20 years, 4.1% or 153 had gross extrathyroid extension involving the recurrent nerve, the trachea, the esophagus, larynx, and the major vessels in the neck. And these are the types of the procedures performed on these 153 patients. The most important message to convey to you and share with you is on this slide, that those patients who had a complete resection, achieving a R0 resection, were able to have a 96% 10-year cure rate without any evidence of loco-regional recurrence. Essentially, these incurable patients were converted to long-term cures by a well-studied, well-planned, and well-executed surgical procedure. When you leave disease behind with a R1 or R2 resection, cure rates drop from 96% to about 60%. So in summary, extrathyroid extension adversely affects prognosis. Complete resection favorably affects outcome. Complete resection reduces the risk of local and regional failure and offers cure in many patients. Thank you.